start, I would like to thank Dr. Saad for his nice invitation. Really, it's a pleasure to participate with you all in mega online courses. Tonight, I have the honor to moderate this very important webinar, as we have two eminent speakers who will discuss two important topics in the field of pain management and anesthesiology. So, let's introduce our first guest speaker. He is our dear and great professor, Dr. Khalid Abdelhamid. Dr. Khalid is a well-known figure and one of the stars in the field of pain management. Dr. Khalid is a professor of anesthesia and pain management, National Cancer Institute, Cairo University, and the president of Egyptian Society of Chronic Pain Physicians. Dr. Khalid tonight will discuss a very important topic in pain management, which is the central pain mechanisms and syndromes. So let's get started and enjoy listening to Dr. Khalid.
السلام عليكم ورحمة الله. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. Today I will discuss a very important issue about the central pain mechanisms and syndromes. As you know, the sensation of pain must end in the central nervous system to perceive the sensation of pain. In some situations, the central nervous system itself plays a role in itself in perceiving the sensation of pain, either secondary to an event or primary disorder in the central nervous system which makes the patient feel pain. This is our society of Egyptian Society of Chronic Pain Physicians. As I told you before, that we did about 15 workshops and one international congress during the last 4 years, and it helps too much to generate young generations.
Your video as well, please.
Yes, yes.
Can you start your video, please?
That's okay.
Not for the screen, Dr. Khalid.
That's okay.
No. Still, we don't see the full presentation for screen.
Slideshow, please.
Share screen.
Yes,
Resume share.
and then open this.
Okay.
Okay. Start to
That's okay.
still, we don't see the full screen.
It's okay.
Open your screen, open your presentation, please.
I open it already.
Okay. I have to stop your sharing and you share again. Okay, you share again your screen, please.
This is okay.
Yes,
Yeah, slideshow now.
full screen, please, Dr. Khalid.
Yeah, here's this one. Yes, that's
It's okay.
yeah, perfect.
Thank you. So I would like to introduce what type of pain, types of pain we know. As we all know, the pain may originate from any tissues except the central nervous system or peripheral nervous system, which is known as nociceptive pain. The pain may originate from peripheral or central nervous system due to lesion in these systems, which is called nociceptive pain and the neuroplastic pain does not manage it. Probably the central nervous system will go in a new state of elasticity, which is called the neuroplastic pain, and the pain can be felt without actual trauma to the tissue or nervous system. This is simply because we ignore the treatment of acute pain and left it to become chronic and lead to these changes in the central nervous system. So we have nociceptive, neuropathic. These are the many types. If will not cured or due to certain environment present in the central nervous system, we can get another type of pain, which is the neuroplastic pain. The neuroplastic pain may be classified anatomically or pathologically. Anatomically can be classified according to origin in supraspinal and spinal cords. Pathologically can be classified into primary cause in the central nervous system, which lead to the sensation of pain, or it is due to secondary cause in the peripheral or central nervous system or the peripheral tissues that lead to secondary change in the CNS and sensation of pain. Here we have some terminology. If we talk about central pain syndromes, it is always secondary and it is due to spinal or supraspinal origin. If we talk about central sensitization syndrome, it is always spinal in origin and it is secondary due to either nociceptive or neuropathic insult causing acute pain which not well treated. If you talk about the central sensitivity syndrome, it is almost always primary. It is due to supraspinal error in the cortex or in the hypothalamo-pituitary adrenal system, which can lead to alteration of the nociceptors and sensation of pain despite there is no injury. So this terminology is very important to remember, and I will repeat it again and again in my presentation. Let us illustrate. Neuroplastic pain can be originated from peripheral generators like tissue trauma or nociceptor sensitization or neuroinflammation and neural trauma, which is due to peripheral insult. These two conditions, if not well treated as acute pain condition and left without management, can lead to central sensitization of the spinal cord and the patient to go into central sensitization syndrome, which is very difficult to treat. As I told you last week about the importance of chronic post-surgical pain and how to avoid it. Or it is due to central abnormal activity, like dysfunction of the central nociceptive system, and this is called in terminology central pain syndrome, like chronic post-stroke pain syndrome and other situation which I will explain. Or it may be due to primary dysfunction of the hypothalamo-pituitary action adrenal system, which lead to a syndrome known as central sensitivity syndrome and so on. So this slide is very important as terminology of the syndromes. These are the common features of neuroplastic pain syndrome. How the patient feels. He feels shooting lancinating pain. He can feel abnormal pain sensations like allodynia, like hyperalgesia, like feeling cold or heat sensation without actual presence, muscle and joint pain without a cause, vascular reactivity pain, and peristaltic visceral pain. These collection of symptoms are not linked together. There is no obvious cause. You can see a patient with migraine and CNS insult told you that with the attack of Central pain syndrome, by definition, is a syndrome caused by neurological condition or dysfunction due to damage or dysfunction of the sensory pathway of CNS, which includes the brain, brainstem, spinal cord. Many causes like stroke, multiple sclerosis, phantom pain, tumors, epilepsy, brain or spinal cord tumor, or Parkinson's disease can lead to chronic central pain syndrome. This slide summarizes some causes, either supraspinal or spinal. We have phantom pain, which is a very famous known syndrome. Central post-stroke pain syndrome, which is a rare syndrome, but we see it so frequently nowadays. Trauma to the spinal, to the brain, supraspinal structures, tumors, multiple sclerosis, and Parkinson's disease. Spinal causes may include phantom pain again, spinal cord injury, syringomyelia, multiple sclerosis, neuromyelitis optica, and the tumors. All these conditions can cause central origin pain, and the term is central pain syndrome. What is the mechanism of the central post-stroke pain syndrome, which was known as thalamic syndrome? Now, this term is become more modulated to another terms, and the most recent term is chronic or central post-stroke pain syndrome. Central post-stroke pain syndrome is due to disturbance of the connection between the thalamus, which is the main relay of pain sensation in the CNS, and the sensory cortex. This new situation, due to injury of the thalamic nuclei or injury to some areas of the central nervous system, the thalamus and the cortex are locked in together in an altered state of activity, lead to abnormal sensation of pain. So it is due to dysfunctional corticothalamic loop along the sensory pain conducting pathway. It was known previously as thalamic syndrome and Digerin-Rossi syndrome, which is the name of the one who explains this syndrome. As I said before, the symptoms: abnormal sensation of cold or heat on one side of the body, abnormal movement, cramps and muscle pain, emotional overreaction. This syndrome is very important to be diagnosed after stroke, to be properly treated by drugs and other interventions. The diagnosis is very important. So you must put in your mind that some cases of cerebral stroke can lead to this chronic post-surgical post-stroke pain syndrome. So if we summarize the central sensitization, the term of central sensitization, please be aware about central sensitization and how to differentiate it between it and central sensitivity. Central sensitization is secondary to a lesion in the tissues, nociceptive or central nervous system, peripheral nervous system. So it starts by peripheral sensitization, lead to spinal cord irritation with high excitatory neurotransmitters, glutamate and B substance and so on. This will lead to sprouting of C fibers in neuromas and other brain pathways, and lead to the apnoea, which lead to activation of more and more dynamic range neurons in the spinal cord. It will lead to a state of hyperactivity of this nociceptive pathway, lead to that the CNS becomes a nociceptive processing mechanism from the spinal cord. So the spinal cord here is the origin of this atomic bomb of pain, which will lead to a state not treated well and not diagnosed well. Many examples of this central sensitization syndrome, like, as we all know, chronic spine pain and chronic post-surgical pain, chronic arthritis, chronic headaches. These are very common situations. the element of central sensitization. Every patient has a magnitude of central sensitization. If we don't treat this percentage properly, we can't treat the pain. Don't believe that the patient has 25 years of pain and I do some sort of intervention and the pain, the second week becomes pain free. This is wrong. This is not okay. We have central sensitization syndrome. It's proved. It's fact. We have to deal with it. If you want to treat pain properly, you have to treat the origin. You have to deal with the pathway by nerve block or frequency or so on, and to treat the central sensitization element of each patient according to many factors: the age of the patient, the severity of the case, the chronicity of the pain, and so on. So don't miss to treat pain in these three aspects. What is the treatment of secondary central pain? It must be etiological rehabilitation, specific pain treatment, and psychotherapy in the form of multimodal and multidisciplinary approach. You can't treat the chronic pain conditions, especially resistant cases, long-standing cases without multidisciplinary. It is not simple an injection or analgesic the patient becomes okay. The treatment of secondary central pain may be pharmacological in the form of tricyclic antidepressants, A2 delta agonists like gabapentin and pregabalin. We have other anticonvulsants like carbamazepine and so on. Opioids play a role, especially if we give it in high doses. Local anesthetic sodium channel blockers, NMD antagonists, and steroids. All these pharmacological drugs can play a role in managing and treating the secondary central pain. The other interventional or non-pharmacological modalities include intrathecal baclofen. You dilute the spinal cord in baclofen or local anesthetic or other drugs or opioids to decrease the hyperexcitability of the neurons in the lamina 2 spinal cord, to decrease the central sensitization. This is the cause of using this. Neuromodulation is the same principle, and of course some surgical management like tracheotomies and craniotomies and so on. Let us go to central sensitivity syndrome. As I told you before, it is primary pain disorder in the central nervous system. There is no lesion, but there is functional disorder lead to sensation of pain. We have no tumors. We have no Parkinsonism. We have no multiple sclerosis. This is central pain syndrome. But central sensitivity syndrome is functional. So, to feel this sensation of pain, you must have genetic predisposition and subjected to some sort of stress or environment. The most famous is chronic complex regional pain syndrome, which occurs after any limb injury or amputation and so on. This will lead to neuroendocrine, immune, and mitochondrial dysfunction. When this occurs, the stress response of the patient to this condition is impaired. So these changes can lead to hyperexcitement of different central neurons, and the patient symptoms with pain constitute the main symptoms of chronic sensitivity syndrome. Simply speaking, the problem here is here. The problem is in the hypothalamus. Start from the hypothalamus. In normal condition, when the patient subjected to any stress, the hypothalamus will release releasing corticotropin releasing factor, go to pituitary and CACTH adrenal cortex glucocorticoids in sufficient amount to deal with the stress. And the muscles becomes intact with no disruption of these muscles. If the patient has predisposition for this syndrome, any chronic or early life stress due to a defect in amygdala and hippocampus, this mechanism is disturbed and the release corticotropin releasing factor will lead to disruption of muscles, which will lead to inhibition of the inhibitory mechanism of pain sensation, which is present all the time, and altered production of the glucocorticoids from the adrenal cortex, and the patient becomes in a state of spontaneous pain without stimulus. The primary condition of central sensitivity syndrome must always supraspinal. The defect, as I told you, is in the hippocampus, in the amygdala, in the hypothalamus. Some syndromes are present like fibromyalgia, chronic fatigue syndrome, which are the most present or the most high percentage forms of central sensitivity syndrome we always see in our clinics. This is interstitial cystitis and chronic this abbreviation I will remember. This is the interstitial cystitis, irritable bowel syndrome, and this is the complex regional pain syndrome. I think this is chronic pelvic pain syndrome. Chronic pelvic pain syndrome is very strange syndrome. In females more, the patient come to you, I have chronic pelvic pain. I went to gynecologist. I do many laparoscopies. I do hysterectomy. I do variectomy, and no relief of pain. Then I went to a neurosurgeon, and I did MRI. There is very small disc prolapse. They think that it is the cause of my chronic pelvic pain syndrome. I did laminectomy. I saw many patients like this. No one thinks that this pain is functional. There is no cause. You have to analyze the pain of the patient. You have to analyze which brings the pain, which relieves the pain, when it begins, after which conditions, the character of pain. This is very important to analyze pain. And don't trust that some minor disruption or pathology you see in the MRI or sonar, or it is the cause of this much pain. The pain will be very severe and associated with other symptoms like fatigue, insomnia, disturbed mood, and so on. So it is very important to diagnose these conditions, which are very painful and very popular to see. But remember that fibromyalgia patient which comes to you and said, I have pain in my whole body. It is known as widespread pain. Widespread pain, go into differential diagnosis for fibromyalgia, chronic fatigue syndrome, other secondary causes like hypothyroidism, like vitamin D deficiency, like osteoporosis. So you have to exclude secondary cause. Fibromyalgia itself, it is very difficult to treat, and it is characterized by remissions and exacerbations. The patient subjected to stresses lead to a fibromyalgia attack, lasts for months. And when the psychological element was improved, there is some regression of the symptoms. But remember that fibromyalgia may be associated with other syndromes of central sensitivity cause. So if you have a case of migraine headache, you have to exclude that migraine headache is associated with fibromyalgia patient or not. You have to examine the patient for the presence of fibromyalgia. You can find patient with widespread pain, fibromyalgia, with migraine, with interstitial cystitis, which is called irritable bladder. The patient go to toilet, especially females, about 30 times per night. There is no sleep. And again, many cystoscopies and many ureteroscopies and there is no evident cause of this. Antibiotics and so on, as you think. Always think of functional element, disturbed function. Also, the patient with fibromyalgia may have irritable bowel syndrome or may have chronic fatigue syndrome. This functional syndromes, I think Dr. Saad can give me another presentation later on for this syndrome. I would like to explain this. So the chronic sensitivity syndrome, many symptoms you can find: the pain, sleep disturbance, sexual dysfunction, fatigue and anxiety, overlapping condition, tenderness to touch, tender point, mood disturbance, dyscognition, and multiple chemical sensitivity to anything, to perfumes, to some drugs, and so on. The treatment of primary central pain must be directed first to the treating hypothalamo-pituitary adrenal and mitochondrial dysfunction in form of what? In form of improvement of lifestyle with psycho and physiotherapy. The patient feels that he is good when he knows what disease he has. If some patient come to you and told her that she has fibromyalgia, and many patients like her have the same condition, and go to the internet and see the groups of patients with fibromyalgia, they told each other what causes pain more, better, and so on, the patient feel better. And told him or told her to improve her lifestyle, not subjected to many stresses, try to accept some pain, to cope with some pain, coping and acceptance. This is very important. There is another specific therapy, either pharmacological or non-pharmacological. Pharmacological, the only 2 or 3 drugs approved by FDA for fibromyalgia are pregabalin and duloxetine, Cymbalta and Lyrica. You can use 2 together in small doses, or you can start by 1 and increase the dose. If no response, you can shift to the other. But fibromyalgia cannot be treated definitely by pharmacological. It is only one mode. So you have to be multimodal. You have to give drugs. You have to advise patients to do physiotherapy. The most 3 physiotherapy tools for fibromyalgia are therapeutic massage by a professional physiotherapist, hydrotherapy, jacuzzi, and stationary bicycle. These 3 modalities of physiotherapy proves to be more effective in treating fibromyalgia pain. So pharmacological, physiotherapy, consult psychotherapist for severe cases, and try to tell the patient to improve her style of life. Also, neuromodulation can play a role, especially in complex regional pain syndrome. The complex regional pain syndrome, which consists of 2 syndromes, as you know, reflex sympathetic dystrophy and causalgia. It's very strange to belong to this central sensitivity syndrome, because it must be triggered by a trauma. So if you see my slide here, I put complex regional pain syndrome with a questionnaire. What is it? It is central sensitivity or central sensitization. I think it is central sensitivity, and most of researchers believe that, and it is evoked by some minor trauma like fibromyalgia, which is evoked by stress. So it's approved that it is a sort of central sensitivity syndrome. The second cause, if two persons, one with genetic predisposition to this syndrome and one without genetic predisposition and subjected to the same trauma, one will develop the syndrome and one will not develop it. Take home message which is very important: beware that there is some degree of central sensitization in almost all chronic and neuropathic pain conditions. You have to believe that. So no effective pain management can be achieved without dealing with central sensitization component. No single injection can relieve pain for long-standing years neuropathic pain. I think beware that there are many functional pain conditions due to primary central sensitivity, the central sensitivity syndrome. And these functional pain conditions must be diagnosed after exclusion of all expected general or local cause. It's very important. Don't think that the patient has fibromyalgia and so on. No. Try to exclude other secondary causes. The fibromyalgia patient, like all patients, he may develop lumbar disc prolapse. He may develop subarachnoid hemorrhage. So if you see a new event that's not explained on your patient by the situation before, and the history suggests that there is some secondary cause, you have to search for and deal with. This is very important. At last, always manage in a multidisciplinary, multimodal approach. This is my advice for chronic pain physicians to be successful in their specialty, this fine specialty and difficult specialty. And thank you.
Thank you, Dr. Khalid, for this nice presentation. As usual, you covered this issue. As we know, central pain syndrome is very complex to understand and difficult to treat. But Dr. Khalid covered the issue regarding the mechanism and management. I have a question, Dr. Khalid. Is there any, from your experience, is there any rule for the interventional pain management for post-stroke syndrome, as stellate ganglion or whatever?
Which syndrome?
Post-stroke syndrome.
I don't know what is this syndrome. What is this syndrome?
Post-stroke central pain syndrome.
Post-stroke. Post-stroke. Yes.
Yes.
I can't hear. Post-stroke. Yes, some surgical. As I told you, neuromodulation and tractotomies can help in some cases.
But there's no rule for stellate ganglion or
no. I don't think there is no rule.
Okay. Thank you, Dr. Khalid.
Thank you.
Now we move on to our second speaker, our great professor, Dr. Sharif Sultan, professor of anesthesia and intensive care and pain management at Ain Shams University. He is going to discuss a very important topic, which is the perioperative management of pain with pulmonary hypertension. So let's get started and enjoy listening to Dr. Sharif.
السلام عليكم ورحمة الله وبركاته. I'm not sure that you've got the screen.
Yeah, we hear you, we see you, but we need to share screen, please. Yes, good man, thank you.
Okay, ready now?
Yes, that's perfect.
This lecture is about the perioperative management of patients with pulmonary hypertension. First, we need to know more about the perioperative risks of anesthetizing a patient with pulmonary hypertension. You all know that there is many factors many perioperative factors that might increase the pulmonary artery pressure and augment pulmonary hypertension. Between these factors are the stressful conditions like endotracheal intubation, pain, starting mechanical ventilation, any inflammatory process or acidosis, and hypothermia, which is frequently encountered in OR all these factors increase pulmonary hypertension. On its turn, pulmonary hypertension induces a status of hemodynamic instability, increase the incidence of postoperative heart failure, postoperative sepsis, and higher incidence of postoperative mechanical ventilation, and postoperative ICU stay, and readmission to the hospital after discharge. Factors that increase the perioperative risk in pulmonary hypertension patients is anesthetizing the patient with heart failure or pulmonary embolism, or having a high-risk surgery like abdominal surgery or thoracic surgery, extending the anesthesia time more than 3 hours, preoperative walk test, 6-minute walk test of less than 300 meters, and the use of vasopressors in the operation. The overall perioperative mortality is between 7 and 24%, and this depends on the primary disease of the patient and the type of surgical intervention done to the patient, with the highest risk for the pregnant women and the patient undergoing emergency interventions. We need to define what is pulmonary hypertension. The normal mean pulmonary artery pressure is about 14 millimeter mercury. If it increases to between 20 and 24, it is borderline pulmonary hypertension. And when the mean pulmonary artery pressure increases at rest more than 24, or on performing exercise of more than 30 millimeter mercury, this is pulmonary hypertension. This is the classification of patients with hypertension, and this classification is important because the classification will go all through the lecture in every chapter of the lecture. Group 1 patients are hypertension due to a disease in the pulmonary artery itself, pulmonary arteriole itself, pulmonary artery hypertension. Group 2 is pulmonary hypertension caused by left side or left heart disease. Group 3 is pulmonary hypertension secondary to pulmonary disease or hypoxemia or respiratory disease in general. Group 4 is the chronic thromboembolic pulmonary hypertension or pulmonary hypertension after pulmonary embolism. And group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. All these factors could be considered pre-capillary pulmonary hypertension except group 2. Group 2 is considered post-capillary pulmonary hypertension with pulmonary capillary wedge pressure more than 15 millimeter mercury. However, group 1, 3, 4, 5 is called pre-capillary pulmonary hypertension with pulmonary capillary wedge pressure less than 15 millimeter mercury. What are the causes and the pathophysiology of pulmonary hypertension in general? The overall pathology constitutes of 3 important things. First, endothelial dysfunction and imbalance between vasodilators and vasoconstrictors in the vasoconstriction. Secondary is vascular remodeling. And third is the in situ thrombosis of the pulmonary arterioles. Take a look now here. On the upper left corner here, we have the healthy artery. And here in the endothelial dysfunction, when endothelial dysfunction starting, with the imbalance between the vasodilator, nitric oxide and prostacyclin, and vasoconstrictor, endothelin 1 and the thromboxane E2, to this end with vasoconstriction. Second stage is the vascular remodeling, in which there is muscularization or hypertrophy of the smooth muscle of the arterioles. And third, we have, and also this includes lay down of inflammatory cells in the wall of the arteriole. Also, there is at the end, there is inside thrombosis inside the vessel of the pulmonary vessels, and this concludes the pathophysiology of the pulmonary hypertension. Now we are going to review the causes and pathophysiology of every group on itself. Group 1 causes, usually this group 1 is an idiopathic disease, hereditary disease, sometimes due to drug and toxin induced, but most famous associated with other diseases like connective tissue disease, AIDS, portal hypertension, schistosomiasis, and chronic hemolytic anemia. This is the cause. These are the causes of pulmonary artery hypertension. The pathophysiology starts here, as you can see, with the endothelial dysfunction, as we said. endothelial dysfunction ends with imbalance between the vasodilator, nitric oxide, and prostacyclin, and vasoconstrictor, thromboxane A2, and endothelin 1. This imbalance end with vasoconstriction and pulmonary hypertension. Endothelin also play another game with inducing smooth muscle proliferation and increased pulmonary vasculature and pulmonary hypertension. There is other two mechanisms that included in vasoconstriction, which is abnormal function or expression of potassium channels in smooth muscle cells. And another mechanism is increased expression of phosphodiesterase 5. When pulmonary hypertension starts, it is followed by right ventricular increase in right ventricular afterload, and this induces a right ventricular hypertrophy and dilation, and this induces a metabolic shift from oxidative mitochondrial metabolism to the glycolytic pathway. Cardiac ischemia follows, and progressive right heart failure starts with decreased cardiac output. This is the pathophysiology of class 1 pulmonary hypertension. Group 2 is pulmonary hypertension caused by left heart disease, whether this heart disease is just systolic dysfunction or diastolic dysfunction, but most frequently is the valve disease. Mitral stenosis, mitral incompetence are most common. Pathophysiology of this is that the left heart disease induces back pressure and reactive changes like vasoconstriction and remodeling of the pulmonary vessels will be on top and follows this. Group 3 is pulmonary hypertension secondary to pulmonary disease. This pulmonary diseases are, for example, COPD, interstitial pulmonary fibrosis, obesity, sleep disorder like obstructive sleep apnea, scoliosis, or just living in high altitude. The pathophysiology of this pulmonary diseases to cause pulmonary hypertension is multifactorial and might include one of these phenomena: hypoxic vasoconstriction, imbalance between vasoconstrictors and vasodilators, loss of capillary bed, inflammatory process, effect of smoking, and the effect of hyperventilation. Group 4 is the chronic thromboembolic pulmonary hypertension, or we call it STEF. This either due to obstruction of the pulmonary vessels with pulmonary embolism, or the presence of thrombophilic factors in the blood like antiphospholipid antibodies, lupus anticoagulants, or elevated factor VIII. The pathophysiology is easy to understand that chronic obstruction in the affected area by the emboli increase the pulmonary artery pressure. However, the non-affected arterioles are also sharing in the remodeling, in the vascular remodeling. This is coming by the shear stress in the non-affected area and starting bronchial to pulmonary venous shunting, starting the inflammatory process, release of cytokines, and this is responsible for the vascular remodeling in the non-obstructed areas away from the areas of the pulmonary embolism. Group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. This include unhomogeneous group of diseases like sarcoidosis, like glycogen storage disease, like Gaucher disease, like chronic renal failure with dialysis. The clinical findings in such a patient is usually the most important in which is dyspnea. However, the patient might complain of bluish labor skin or cyanosis, anginal pain, feeling of arrhythmias or fluttering chest sensation, dyspnea or shortness of breath, fatigue or weakness. Patients usually complain of tiredness and lightheadedness and near syncope. Dry cough is common. And if the patient starts to go in right ventricular failure, there will be abdominal bloating, rapid weight gain, and swollen ankle or legs. These are the usual clinical findings in pulmonary hypertension. The overall management is according to the group. Group 1, usually the management is pulmonary vasodilator. We are going to discuss pulmonary vasodilators in few seconds. Other drugs included like oxygen, diuretics, and anticoagulants. Group 2 management is mainly directed to the left heart failure. The use of pulmonary vasodilator might increase the magnitude of the disease because of the pulmonary edema that follows the use of the pulmonary vasodilator, so they are not indicated in such a group. Group 3 is management is directed toward the pulmonary disease. And again, pulmonary vasodilator are not indicated in this group because they might induce VQ mismatch for these patients. Group 4 management is mainly surgical, and pulmonary vasodilator may be used if the patient is not surgical candidate. Group 5 management is directed to treat the cause. Now we need to talk about the pulmonary dilators and the available drugs and drugs of pulmonary dilation. Pulmonary dilators are one of three signaling pathways, either the endothelin signaling pathway, or prostacyclin signaling pathway, or nitric oxide signaling pathway. Here we can see that the endothelin pathway the endothelin is produced in the endothelium and then passes inside the arteriole to manage effect of vasoconstriction through endothelin A and B receptors. Blocking these receptors will affect the effect of the endothelin 1. The prostacyclin pathway, prostacyclin I2, which is prostaglandin I2, is produced in the endothelium and passes inside to the smooth muscle cells to increase cyclic AMP production, and thus is responsible for vasodilation and anti-proliferation. Nitric oxide pathway includes the nitric oxide produced by the endothelium and passes inside the smooth muscle cell to produce cyclic GMP through activation of guanylate cyclase. And other drugs could be used as the phosphodiesterase inhibitors, which decrease the breakdown of cyclic GMP, and so vasodilation and anti-proliferation is produced. To review these drugs, we have the endothelin system, endothelin A receptor, endothelin B receptor. They are blocked with these drugs, bosentan, ambrisentan, and macitentan. The bosentan is a very important drug, and it carries a very high incidence of side effects, including major birth defects, so it is not given for the pregnant ladies. Blocking these receptors end with vasodilation. Here is the prostacyclin pathway. We have the drugs iloprost, treprostinil, and ipoprostinol. These drugs affect the adenylate cyclase and form a big amount of cyclic AMP producing vasodilation. Nitric oxide itself stimulates guanylate cyclase, and sildenafil and tadalafil decrease the breakdown of cyclic GMP, and so there is vasodilation again. Therapeutic approach, usually according to the severity of the disease, class 1 or 2 or 3, usually receive oral phosphodiesterase inhibitors like the sildenafil, or oral endothelin receptors antagonist, or inhaled prostacyclin. Heavy methods like IV prostacyclin or sub-Q prostacyclin are used with patients with class 4, 3, or 4. What is the preoperative workup should the anesthesiologist know and practice? First, the clinical examination. As we said before about the clinical findings, we explained it before, but unfortunately, it is largely unspecific and easily overlooked or misinterpreted in early diseases of the early stages of the disease. The most common, but unfortunately very unspecific symptom is stress-induced dyspnea. Moreover, the anesthesiologist should search for the symptoms of right-sided heart failure, like distended jugular vein, like abdominal swelling, like dependent edema, and the enlarged liver and spleen. The anesthesiologist should put the patient in his functional classification according to the WHO classification. This classification depends on the physical activity of the patient. Class 1 having no limitation of physical activity. Class 2 have slight limitation of his physical activity, however, the patient can perform his ordinary activity with few symptoms. Class 3, the patient is complaining of marked limitation of his physical activity and cannot perform his usual activity throughout the day. Class 4, which is usually here the patient is right ventricular failure, the patient is unable to perform his physical activity without symptoms. He is complaining of symptoms at rest, and these symptoms are in the form of dyspnea or near syncope or arrhythmias sometimes. We need also to put the patient in exercise tolerance. We perform 6-minute walking distance, and if this distance is less than 300 meters, the patient have got higher mortality with going to the OR. Chest X-ray findings for pulmonary hypertension are in the form of here, the right atrial enlargement, right ventricular hypertrophy, the main pulmonary artery is dilated, right pulmonary artery is dilated with ends-on views, cuts-off view, and the peripheral pulmonary parenchyma shows vascular rarefaction. ECG findings are in the form of right axis deviation. We have also right ventricular hypertrophy evident in increasing the QRS complex in V1, V2, V3. Right atrial enlargement with the tall P wave, peaked P wave. Right ventricular strain in the form of inverted T wave and disrupted ST segment. We have also sinus tachycardia, and in some patients we have right pulmonary branch, right bundle pressure block. We usually perform pulmonary function test and ABG for patients with chronic lung disease. Echo is very important for these patients. Echo is the non-invasive method with the highest sensitivity and specificity of diagnosing the pulmonary hypertension. Echo also can accompany all our journey before OR and inside OR with the TEE and post-operatively in the ICU. Echo also can diagnose reasons for pulmonary hypertension like left ventricular dysfunction, valvular insufficiencies, and shunts. Echo findings are in the form of dilation of the right cavities, right atrium and right ventricle, compression of the left cavities, left ventricle and left atrium, and the presence of precardial effusion. Right heart catheterization have got the definitive diagnosis. It have also the importance of giving the direct measurement of hemodynamic parameters, and it can estimate the severity of the disease. And what's important for us, it determines the pulmonary vascular reactivity to inhaled vasodilators. The patient should carry a report at least 3 or 4 months before the operation, before going to OR. What can the right heart catheterization read? You all know that it can read the right atrial pressure, direct measurement of right atrial pressure, right ventricular pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, direct measurement also of CVP, cardiac output, and mixed venous oxygen saturation. Indirectly, with few equations, we can estimate systemic vascular resistance, pulmonary vascular resistance, cardiac index, systemic, stroke volume index, left ventricular stroke work index, right ventricular stroke work index, oxygen delivery, and oxygen uptake. We need to optimize the primary disease therapy before going to OR. If the patient have got urgent surgery to be done, cannot be postponed, we start at least sildenafil 50 to 100 milligram per day and L-arginine 15 gram per day as precursor for nitric oxide. At least we can differentiate between the pre and post capillary pulmonary hypertension with the use of echo and right heart catheter. We need also to continue some medication like calcium channel blockers, digoxin, diuretics, prostaglandin infusion, sildenafil. And if the patient is under warfarin, we need to bridge it with low molecular weight heparins. Intraoperative management should include basic monitors. These basic monitors are in the form of ECG, saturation, entitled CO2, invasive blood pressure, temperature measurement, and evaluation of stroke volume variation, which is very important because it evaluates the volume responsiveness better than the CVP. And there is advanced or extended monitors like the using of pulmonary artery catheter. However, pulmonary artery catheter induces transient ventricular arrhythmias and might induce pulmonary artery pressure, so that it is not indicated in this patient. We can also use the TEE, which optimizes the fluid use and detect ischemia and monitor pulmonary artery pressure and tricuspid regurg, and also can manage in the help in management of the patient intraoperative. Also, we can use the central venous oxygen saturation. The choice of anesthesia, we either can give the patient general or regional block like spinal, epidural, catheter plexus block, or nerve block. Any regional block gives the advantage of giving the patient the keeping the spontaneous breathing of the patient intact. In regional blocks, usually we don't need to intubate the patient and start mechanical ventilation, and both increase the pulmonary pressure. We can extend the regional block for post-operative analgesia with the catheter technique, and there is less anesthetics and opioids used inside OR, and this might affect the central ventilation of the patient. If the regional block is concerning plexus block with catheter or nerve block with catheter, the advantage increase with low failure rate and no hemodynamic effects for bolus injection. However, regional blocks have got many disadvantages. First, that the bolus injection, for example, spinal anesthesia, it will increase the systemic vascular resistance, decreasing the venous return, decreasing the coronary perfusion, and right ventricular failure might start. So spinal anesthesia with bolus technique should be avoided. Maybe replaced by catheter technique and slow increasing volumes or doses from the spinal anesthetic. The same with the induction of epidural analgesia. Administration should be fractionated and top-up doses are increased one by one until we reach the desired level and the desired strength of block. This is number one. Number two, the positioning. It may be difficult to maintain spontaneously breathing patient in certain positions for a long time. At this time, we need to give the regional block with general anesthesia. Number three is that most of the patients are under anticoagulant, and this, as you know, might disrupt the whole plan of the regional anesthesia. Number four, if the block is coming high for spinal or epidural, coming high block to T3 or T4. So there may be a magnitude of sympathetic blockade, and this will decrease the myocardial inotropy and chronotropy. Last of this is that the spinal anesthesia, for example, or central neuroaxial block, when it induces hypotension, how can we treat the hypotension? Treat it with fluid. In group 2, pulmonary edema will result. And all the other groups, right ventricular fluid failure might follow the fluid administration. Okay, let's treat the hypotension with vasoconstrictor like epinephrine. Maybe the pulmonary artery pressure increase, right ventricular afterload increase, and right ventricular ischemia follows. So it is very difficult to maintain the blood pressure of this patient under regional anesthesia. On the other side, general anesthesia have got advantage of safe oxygenation and uncomplicated airway management. And more important is that giving the inhaled dilators in an easy, precise, reliable delivery way and delivery dose of the inhaled dilators. However, there is some disadvantage of general anesthesia that induction might increase or decrease the blood pressure. Most of the anesthetic agent induces vasodilation and hypotension. Starting mechanical ventilation in patients with pulmonary hypertension might induce hypotension, and hypotension in this patient might induce coronary perfusion, decrease the coronary perfusion, and the myocardial ischemia. So if we are going to give the patient general anesthesia, induction gonna be in this way. All the intravenous anesthetic could be used except for ketamine, which is not recommended for these patients. Narcotics, we can use fentanyl, so fentanyl or whatever the narcotic needed according to the strength of surgery, according to the depth of anesthesia we need, but we must probably avoid use of morphine because of the histamine release. Muscle relaxant also, we avoid the histamine releasing relaxant like atracurium because of affection of more increase in pulmonary artery pressure. Volatile anesthetics, we could use all the volatile anesthetics up to 1 mg because up to 1 mg, they have no negative effect on pulmonary pressure or resistance. Nitrous oxide is not recommended for these patients. Intraoperative management, we need to set our goals for the intraoperative management for this patient. Many factors, as we said, affect or augment pulmonary hypertension, like hypoxia, acidosis, pain and distress, hypothermia. So we need to avoid all these 4 things. Decreasing systemic vascular resistance, as we said with the spinal anesthesia, for example, decrease the pulmonary, the right ventricular preload. So we need to treat and prevent these 2 things. Decreasing the right ventricular preload with fixed pulmonary venous resistance due to pulmonary hypertension will induce a reduction in cardiac output. So we need to fight against the decrease in systemic vascular resistance and the decrease in right ventricular preload. There is many factors we need to avoid so as not to affect the right ventricular ischemia and right ventricular failure, like decreasing the myocardial contractility, decrease the systemic blood pressure to reach the same or below the pulmonary artery pressure, and increasing the right ventricular afterload. The goal summary or the overall summary for the goals we are going to use is that we need to keep the systolic pressure above 90, mean blood pressure above 65, mean pulmonary artery pressure below 35, the balance between the pulmonary vascular resistance and the systemic vascular resistance below 0.5 by keeping the pulmonary vascular resistance dilated and maintaining the systemic vascular resistance and keeping the cardiac endings more than 2.2. This is how we put the goal for our OR management. Or we can use the results in the right heart catheter as target values and start the intervention when there is deviation in these values to between 15 and 20%. So we need now to avoid hypoxia. How we can avoid hypoxia? You all know this. We can increase the inspiratory oxygen, FiO2 between 0.6 and 1. We can do some maneuvers to recruit the lungs to avoid ventilation-perfusion mismatch. We need to start the low tidal volume strategy with the tidal volume 6 to 8 ml per kg to avoid overinflation of the alveoli. We need to avoid acidosis, respiratory acidosis by moderate hyperventilation with target peak arterial CO2 of 30 to 35 millimeter mercury. We need to avoid the metabolic acidosis by keeping the pH below 7.4, and if needed, we can give the bicarbonate. We have to avoid hypothermia by maintaining the body temperature between 36 and 37, and you know all how to do this. We have to avoid pain and distress by ensuring good depth of anesthesia and analgesia. Also, you know how to play this game. We need to maintain the systemic vascular resistance. By avoiding bolus dose in spinal and epidural anesthesia, use small frequent doses of these drugs. We need also to avoid the intravenous vasodilators because they affect the pulmonary vasodilation and also systemic vasodilation. Better to use the inhaled vasodilators. We are going to talk about this. We need to maintain the right ventricular preload by giving proper fluid utilization, and this is very crucial for this patient. We need to use the restrictive strategy in giving the fluid for this patient in a targeted manner under adequate hemodynamic monitoring. And in the same way also to maintain the systemic vascular resistance as we said in the previous slide. We need to avoid the breast contractility by maintaining the contractility of the patient. Don't increase the volatile anesthetic more than 1 mg and avoid beta blocker usage inside OR. We need to maintain the systemic blood pressure above the pulmonary artery pressure. If the pulmonary artery pressure, for example, is 90, you have to increase the blood pressure more than 90. Don't allow this systemic blood pressure to fall to 90 or below this, because this will induce right ventricular failure in rapid way. We can use epinephrine, norepinephrine, vasopressin, levosimendan, or dobutamine, but all these things have got weak recommendation. The strong recommendation goes to the phosphodiesterase 3 inhibitors like the milrinone or amrinone. We have to avoid and treat increasing right ventricular afterload. In another way, we have to dilate the pulmonary circulation. To dilate the pulmonary circulation in a way or another, we can use intravenous dilator, but it is not preferred, or inhaled dilators. Intravenous dilator like nitroglycerin, sodium nitroprusside, milrinone, dobutamine, prostacyclin, or intravenous sildenafil, or the inhaled dilator like nitric oxide, or what we call nitric oxide alternatives like prostacyclin or iloprost, milrinone, or treprostinil. The intravenous dilators, the best of them is the milrinone, because it affects the pulmonary resistance more than affecting the systemic resistance. It also keeps a good contractility for the heart and suitable even with if the patient have got unstable hemodynamics. However, if the patient is very hypotensive, we can omit loading dose of the milrinone. Dobutamine is not used because of the limited use due to its tachycardia. Now we need to talk about the inhaled vasodilator therapy, whether this inhaled is nitric oxide or other drugs. Advantages of inhaled vasodilator therapy is that the local delivery to the target organs. We can give big amount or high concentration of the medication directly to the target organs, which is the pulmonary arterioles. Advantage is avoidance of systemic effect, including systemic hypotension, and delivery to the ventilated alveoli, allow keeping the VQ mismatching in a good way and good gas exchange. Overall, total dose is low and the cost is overall is low. Disadvantage of inhaled vasodilator are, some of them are irritant to the airways, like milrinone, irritant to the bronchi. Delivery of these drugs might be affected in patients with chronic bronchial affection, like asthmatic patients. The delivery system of these drugs may be cumbersome and time-consuming, and sometimes it is very costly, like the nitric oxide is very costly when it is used in the hospital setting. Nitric oxide, the overall of nitric oxide is that advantage is rapidly acting. Nitric oxide within few minutes give the desired effect, and also have a rapid offset with no systemic effect due to combination with the hemoglobin to form methemoglobin. Overall profile of nitric oxide is a very safe drug. Disadvantage of the nitric oxide is that it is very expensive technology to administer to the patient. Short duration with some patients need long-term treatment, necessitate continuous administration of nitric oxide. Nitric oxide requires cumbersome portable tanks, which is not suitable for outpatient use. For good and best management of nitric oxide, it should be accompanied with mechanical ventilation of the patient to ensure precise dose delivery to the patient. Nitric oxide also have got the disadvantage of, if it is used for prolonged time and high dose, high percentage of patients are converted to non-responders. There is also a rebound phenomena in this case, and direct toxic effect to the lung cells might happen with the patient. The mechanism of nitric oxide is that the nitric oxide passes from the endothelium to the smooth muscle and stimulate a big amount of cyclic GMP, which produces protein kinase G, which decreases the calcium uptake by the cell and increases the calcium uptake by the sarcoplasmic reticulum, and relaxation follows. This is the machine used for nitric oxide application. Nitric oxide alternatives are some drugs that we are using as intravenous, but now we are using as inhaled therapy. How can we give these drugs to the patient inside OR? Either through a jet nebulizer. This is the jet nebulizer. The jet nebulizer connected to the flow meter here, and also connected to a syringe pump to give to deliver the inhaled solution directly to the jet nebulizer. And the jet nebulizer usually is attached to either the inspiratory limb or the Y limb, after the Y limb near the patient to be delivered to the patient. This is the jet nebulizer. Another picture for the jet nebulizer here is connected to the patient with a TPS. This is the jet nebulizer. Another way to give our drugs is the ultrasound nebulizer. Ultrasound nebulizer, we need to perform a trick to give the patient the nebulized drug. This is, as we can see, sorry. As you can see here, this is the expiratory limb of the machine, and this is the inspiratory limb. The inspiratory limb divides in two: one to the going to the tube directly, and another one going to the ultrasonic nebulizer, and then delivering the drug directly before the endotracheal tube. We can see here, this is the patient ventilated under general anesthesia. Other way of using the mesh, the vibrating mesh nebulizer, which is easy to use and no need to use with afferent oxygen or afferent inspiratory limb. What are the drugs used now? We have the prostacyclin. It's a short-acting drug with half-life of 2 to 3 minutes. So most of the systemic effect is not happening. No hypotension happening with the inhaled prostacyclin. And for precise dose delivery, it should be in a controlled, ventilated patient. Other than the prostacyclin, we have the iloprost with longer half-life, 20 to 30 minutes. The inhaled iloprost, usually we use the ultrasonic nebulizer, not the jet nebulizer. And due to its longer half-life, sometimes the systemic effect is happening with this drug. Other than the iloprost, we have the treprostinil, which is having a longer half-life than the iloprost. And what is common and available in OR is the milrinone. Milrinone have got a very strong dilator, bronchial dilator, pulmonary dilator. But however, it is a little bit irritant to the airways and need to be diluted, 5 milligrams diluted in 15 ml and giving over 15 minutes. Post-operative care for this patient should extend to be inside ICU, at least 24 hours for small intervention and maybe for several days for major procedures. Anesthesia should continue as continuous regional block. If the patient is complaining of arrhythmias, we are going to use amiodarone and not beta blockers, and sinus rhythm cannot be, if sinus rhythm cannot be restored, we can use digoxin for rate control. Thank you very much.
Thank you so much, Dr. Sharif, for this great and informative lecture. Discuss the causes, pathophysiology, and perioperative management in a simple and clear way. I have got several questions. Let me ask. Someone asks how to measure central venous oxygen saturation.
Either through the CVP or through the insertion of the pulmonary artery catheter. But however, we said before that pulmonary artery catheter is not indicated in this patient. But the monitors that can measure the central venous saturation can measure it through the central venous catheter.
Second question, does phenylephrine give any advantage over ephedrine in treatment of hypotension after regional anesthesia in pulmonary hypertensive patients?
The only advantage of such a drug is that it is shorter time than the ephedrine. If you give the ephedrine, you all know that it will last at least 20 minutes. Phenylephrine might last for few minutes. So this is the only advantage. However, fluid management and vasoconstrictor giving to patients with pulmonary hypertension is very, very crucial for this patient and might induce detrimental effect and right-sided failure might be in few, I can say few minutes, not few hours even. So overall, regional anesthesia in general, with the pulmonary hypertension increases, the regional anesthesia should decrease.
Okay. One more question. How can I use dobutamine in pulmonary hypertension despite it causes vasoconstriction.
We said that it is one of the dilators we can use, and we said that it is not preferred because of the sinus tachycardia. It induces a patient comes already in sinus tachycardia, and the dobutamine also increase the heart rate, so it is not preferred. However, we mentioned that theoretical drugs could be used or could be considered as pulmonary vasodilators.
Thank you again, Dr. Sharif.
Thank you.
At the end, I'd like to thank all the attendees, organizers, and our guest speakers. Thank you.
Dr. Ahmed, I have one question for Dr. Khalid. Sorry for that, because we don't ask Dr. Khalid today. So my question, you know that, thank you, Dr. Khalid, because you make something very complicated to be a simple thing, you know. But every now and then we can see in Facebook or just in other media, some people just make management for a patient, treating him and the patient 25 years with pain and disability, and the patient jump from after this injection. What you can see for these people, what is the target for chronic pain management, like acute to complete relief of pain or what?
Thank you for this question, Dr. Yasser. I think what you see on Facebook and other social media and advertising tools, it is a sort of marketing for something they think it is possible to make the patients believe, these miserable patients believe that there is only one injection which is a magic, and the patient becomes okay after this injection or radiofrequency. In many cases, I don't know which place they do radiofrequency. I think some cases there is no nerve affection, there is no access to the nerve, and they write, we do radiofrequency. Radiofrequency or what? So they are, first of all, they are beginners, and they have lack of knowledge that the chronic pain management is a multimodal, multidisciplinary art. It begins with a proper diagnosis. As we learned from Professor Omar Tawfiq, rahimahullah, that the chronic pain, you must diagnose the origin of pain origin, and then you can manage. If you don't know the origin of pain, you can diagnose the cause of pain. Be sure that your management will be a big failure. You are a big liar if you told the patient that I will do this for one time, and you will walk and you will go to club and you will play football and so on. This is wrong. They are beginners. They have to learn how to deal with the chronic pain patient. There are many aspects of chronic pain generators. The origin of pain, as I said, you have to deal with, if you can deal with the origin of pain. The pathway of pain with radiofrequency and nerve blocks and so on, and the catheters and this is the second modality. And the third modality, you have to treat the psychosocial element and the central sensitization, hypersensitization, which occurs in the spinal cord or in the CNS. This is very crucial, and this is very important.
Thank you, Dr. Khalid.
Thank you.
Thank you all. As I said at the end, I'd like to thank you all the attendees, our guest speakers, and the organizers for this great webinar.
Thank you.
Thank you very much, everybody. Thank you very much, our talented, distinguished speakers and the moderator. And thank you very much to Dr. Yasser from Qatar, Dr. Ahmed Zaghloul from Cairo University, and Dr. Khalid, Professor Khalid Abdel Hamid, and Professor Sharif Sultan. Really, I am really very thankful myself to the MEGA online course, which made me introduced to all those talented people all over the world. I want to be dreamed one day I meet all of you like this tonight here. I only hear about all of you in the conferences, big scientific meeting, and like what I heard from my colleagues are attendees. They always give me feedback that they are very grateful to all our speakers. And every time they don't believe that we get all of those talented people to talk to them freely at their home, at their out of reach, and when they are in duty, they can listen to a very, very important lecture like Professor Khalid Hamid tonight and Professor Sharif Sultan. They could be traveling miles and miles, days and days, to listen to those two lectures like tonight. The man behind the scene is Mr. Dara Walsh, is putting a huge effort on the audiovisual to make those lectures are available in your hand at immediately after we finish the webinar, not to miss anything at all. Thank you very much for being here tonight. I'm really very grateful to all of you. I couldn't thank you enough. And Anna from Canada, and Dr. Doha Sanhori from Alexandria, Dr. Imam from Asyut. Thank you very much, everybody, and good night.
Good night. Bye.
Good night. Our pleasure.
Thank you.